recording. So let us begin.
Sure.
Okay. Good afternoon, everyone. Thank you all for joining us today for technical info session on latent TB detection. As many of us know, latent TB infection is a state of immunity against Mycobacterium tuberculosis without any evidence of an active TB infection. Nearly 40% of Indian population today lives with latent TB infection. Therefore, early detection of latent TB plays a major role in ascertaining treatment strategies to avoid latent TB turning into an active form. Understanding how we can detect latent TB, today we have with us our speaker, Dr. Gautam Wankhede, sir. He is the Director of Medical Affairs at MyLab Discovery Solutions. With 19 years of diversified healthcare experience, he leads medical strategies that support successful product development and commercialization. He is also responsible for developing comprehensive, clinically evaluated, scientifically structured communications and go-to-market plans for products. Welcome, sir.
Thank you, Deepthi.
In our today's discussion, we would be focusing on differential rates of latent TB, prevalence of latent TB on a global and Indian scale, significance of site TB in the accurate detection of latent TB, and advantages of using site TB for early detection and treatment for latent TB detection. I would request everyone to, if at all there are any queries, to kindly put them in a question answer session. We would take them at the end of the discussion. Sir, I would like you to go ahead further with the discussion.
Okay, thanks a lot, Deepthi. And first of all, on behalf of MyLab and Serum Institute of India, I welcome all of you to this session. And we'd like to discuss about this very exciting new product that we are launching now in India. It's by the name of Site TB. And it's the next generation skin test for the detection or diagnosis of latent tuberculosis infection. So we'll go a little bit about on the background and understand the history of TB in India. I won't spend much time on that. And then we'll come to the point of why is latent TB testing important and how is that going to play a very big role if India has to lead the world in eliminating tuberculosis. So historically speaking, tuberculosis has been around for centuries. And when we talk about TB in India, it was about 110 years back that there was the first All India Sanitary Conference, wherein research scientists and clinicians came together and spoke about TB and how to manage TB. However, it's been 110 years now, and India still, unfortunately, is a global leader in tuberculosis. So we contribute nearly 30% of all cases of tuberculosis out of the nearly 1 crore people affected in the world. And more importantly, the number of people dying of tuberculosis even today in India is very high. About 5 lakh deaths were reported just in 2020-21. And when we talk about deaths, unlike a lot of other diseases, TB also happens to be a chronic disease. So if the mortality is about 5 lakhs, think about the morbidity. Think about how much the lifestyle or the families of such people are affected. So it's very important to fight this menace with our full force. And that's where I would say in the last 5 to 7 years, we've taken some very strong steps. And we've now reached a stage where we are talking about eliminating TB. We're not only talking about diagnosing or managing it. So this is where we are right now, where we have taken a step where we have to eliminate TB in India by 2025. But to understand how to eliminate, it's important to understand a little bit about the pathophysiology of the disease itself. So basically, it's a bacteria. Once it enters the human body, and it's there, it's an airborne disease. It's fairly common in countries like India. So once it enters the human body, a lot of things can happen. A person may respond to it and eliminate it completely, or this latent or this tuberculosis bacteria may stay inside in a very, very small area surrounded by a sheath, something known as granuloma. This person will not have any infections or any diseases or any clinical symptoms per se. The next thing that can happen is the person can have a subclinical disease, a very, very small lesion, a small patch on the lung or something in the bone, but very limited clinical symptoms. Or the next thing that can happen is the person will not be able to fight this tuberculosis bacteria, and he or she will develop into a full-on active tuberculosis case with clinical symptoms such as cough, fever, weight loss, night sweats, and depending on which part or which organ of the body is involved. And finally, the most dreaded part is if such a person is infected with mycobacteria having multiple drug resistance. So my lab and serum have a large number of solutions which can help in diagnosing all these conditions. We have our kits to diagnose active TB. We have all our kits to diagnose multiple drug resistance TB. We have handheld X-rays to diagnose cases of subclinical tuberculosis with very small lung lesions. We have certain devices to ensure that sputum is generated or sputum is mobilized to collect, to diagnose using sputum. And then obviously what we are talking about today is PSI TB test, something to detect latent tuberculosis. We're also working to come out with the RBCG vaccine to prevent tuberculosis in the grown-ups. But today our focus is going to be on latent tuberculosis. So why are we worried about it? A person with latent tuberculosis, as we saw in a few previous slides, does not have any symptoms. He does not feel sick. The good thing is that such a person cannot transmit TB to other diseases, to other patients, has a normal chest X-ray. Now we know that we can diagnose these patients and also manage these patients. But when it comes to the whole goal of tuberculosis elimination, diagnosing patients with latent tuberculosis becomes very important. Why? Because as most of the persons who have latent tuberculosis will not develop a fulminant disease, but 10 to 15% of the cases, as they grow in age, or if there's any reason for the immunity of such a person to go down, will develop into an active disease, a disease that can be transmissible as well. So what we call as latent TB cases can be called as the sleeper cells, which means that at this stage, they are not active. At this stage, they are not going to spread the disease, but maybe later on down the line, such persons may develop into active TB cases and start causing, spreading the disease further. So if you have to eliminate TB, it is important to identify active cases, but it is equally important to identify cases of latent tuberculosis and manage them. And that's why the focus has now shifted to something known as the TPT, tuberculosis preventive therapy or treatment. So basically, what is tuberculosis preventive treatment? It means simply identifying patients with latent tuberculosis, having a special regime to treat them. This medicine regime is not as extensive or as thorough as the active TB disease. It's a smaller course, lesser medicines, less side effects, but it can be managed, and latent tuberculosis can also be eliminated. So it's important to identify cases of latent tuberculosis. Now, classically, one way of identifying cases with latent tuberculosis was to do the TST, the tuberculin skin test, wherein we inject purified protein derivative intradermally and look for a delayed hypersensitivity reaction, which means that we're trying to see if the T lymphocytes of that person release a certain kind of cytokine in the skin when such a person is exposed to mycobacterium protein. So this was the classical way of carrying out the latent TB test. However, this way suffered a major problem when BCG vaccination became common. So all of us, especially in countries like India, have been vaccinated with BCG, which means that even though we've not got the infection in our body, during vaccination, our body has been exposed to certain tuberculosis proteins. Now, if in such a person, we carry out a TST, we will get a positive reaction. not because the person has an active infection, not because the person has latent tuberculosis, but because he or she has been given BCG vaccination in the past. And that's how to overcome this. Scientists came out with something known as a interferon gamma release assay, wherein blood was taken from such patients. This blood was exposed to certain purified proteins from tuberculosis bacteria, which were not present in the BCG vaccine. And when such blood was incubated with these proteins known as ESAT6 and CFP10, the T lymphocytes released interferon gamma, which is basically a cytokine which is meant to be released when a person's immune system recognizes something as foreign. Okay, and this is the basis of what is known as interferon gamma release assay. So currently there are two well-established assays. One of them is by the name of quantiferon gold. The other one is by the name of TB spot test. What we do in this, we collect blood. As you can see, we collect peripheral blood. We incubate this blood in a laboratory, and then we see for the release of interferon gamma. And then based on that, we find out what are the readings. So a good test, a well-established test, but it has certain shortcomings because it requires, number one, a specialized laboratory. It requires specialized instruments and is a much more difficult to carry out test. Now, as a replacement of this test, what MyLab and Serum have come, they've come together and we've come out with an equally sensitive test, which is fast, accurate, and cost-effective. And this is the test by the name of PSI TB. It is a next generation skin test. So as far as the procedure is concerned, it's exactly similar to the tuberculosis, the TST, the tuberculosis sensitivity test. But what is different over here is, unlike the proteins which are used in TST, which cross-react with BCG vaccine, over here we use ESAT6 and CFP10, similar proteins as used in the IGRA assay. And because of that, there is no cross-reactivity with a person who has been vaccinated with BCG in the past. And that's why PSI TB has become a very good test for the diagnosis of management of tuberculosis. It is unaffected by BCG vaccination. It is an easy replacement to an age-old test known as the PPD or the Montoux test. In fact, WHO also now says that the tuberculosis antigen-based skin test, the TBST, are a very important tool in managing TB by diagnosing by using them to diagnose latent tuberculosis. So this is a pictorial depiction of what I was trying to say. If you see on the left side, the ESAT6 and CFP10, now these are the proteins that are being used over here, which are not present in the BCG vaccination or a non-tuberculosis mycobacteria. So this is what PSI TB skin test is all about. The administration technique is the simple old intradermal injection technique used in Montoux. It comes in the form of a pale yellowish liquid, which is to be stored at 2 to 8 degrees centigrade. And the interpretation is just the way we do it for Montoux test. I'll come to that in the next few slides. So indications, obviously, when you want to diagnose someone with latent tuberculosis, when you have to look for a patient who's been exposed, who's a close contact of someone who has known active TB, or there are certain other special patient groups. For example, people infected with HIV, people who will undergo who are immunocompromised. So they might be undergoing therapy for transplant. There are also many cases, especially in the gynecology area, where people have infertility because of latent tuberculosis apart from active. So in all these areas, these population groups can also be tested for the presence of latent tuberculosis and managed effectively now. So this is the technique, nothing new about it. Most of you who've been in healthcare would know what Montoux technique is. It's basically the administration on the volar surface of the skin of the forearm, in the middle 1/3 of the forearm. We just inject about 0.1 ml of the solution intradermally. We look for a very small bleb because it's important to not go in the subcutaneous area or intramuscular. It's very important that this injection stays in the intradermal area only. We see a small bleb. And then how do we evaluate the reaction? The person is to be examined after 48 to 72 hours. And we simply measure the induration or the thickening of the skin in simple terms. So any induration more than 5 mm, there's a single cutoff of 5 mm over here, is considered as a positive test result, which indicates infection with Mycobacterium tuberculosis. Normally, the induration or erythema will decrease in 4 days and completely disappear in 28 days. So it's very important to do the reading between 2 to 3 days. No specialized equipment required, no readers required. You can do the reading with simple human eye and with a scale as well. So this is the difference we just wanted to create to let you know between a TST, the tuberculosis skin test, the IGRA, and the MyLab serum PSI TB test. Accuracy between PSI TB and IGRA is exactly the same. TST will give you false positive results, especially in cases who've been vaccinated with BCG or a non-tuberculosis mycobacteria. It is very cost effective as compared to the kind of equipments or the kind of infrastructure that is required for IGRA test. No need for a laboratory, no need for specialized readers. We are also developing a patient linkage system, something like a smart patch, so that you can click the photo and then all the results can be interpreted automatically and stored. But this is under development right now. It can definitely diagnose latent TB and it is not affected by BCG vaccination. So that's the biggest advantage of PSI TB as compared to CTB, to TST. We've done a large number of studies across the globe before obviously this test was found safe enough, good enough to be used in humans. We've also done multiple studies in India. In fact, this is one of the tests which has now been recommended by ICMR for diagnosing latent tuberculosis after multiple studies were done in India as well. As I was telling you, the storage is about 2 to 8 degrees, so any regular refrigerator is good enough. You just have to take out the vial from the fridge about 5 minutes before the injection and then use it on the patient. In fact, WHO has also now given a lot of importance on what I was calling as the TBST, tuberculosis antigen-based skin tests. And they came out with rapid communication in 2022 that they can adopt the TST-based IGRA as a form of identifying latent tuberculosis. Coming to India, as I was telling you, India is putting a lot of emphasis on tuberculosis. In fact, we've decided to, go full on, move from a tuberculosis management or control program to a tuberculosis elimination program in the last few years. And MyLab and Serum have a large number of solutions, as I was telling you earlier, in this particular sector. So this is one of the algorithm given out by the NTEP, National Tuberculosis Program. And whether it's diagnosing patients with active tuberculosis, whether it's diagnosing patients with latent tuberculosis, or diagnosing patients for a lesion in the lung with a X-ray, MyLab has a large number of solutions which can fit in various parts as far as this, the TB spectrum is concerned. So with that, I'd like to end this small session of mine, and I'll be happy to answer a few questions if we have enough time for that. Thank you.
Thank you, sir. So anybody, if there's any questions, I could see there are people who are raising hands, and I would request everybody to please drop in your questions in the Q&A section, and Dr. Gautam will address them one by one. We'll address them one by one. I have a few questions, sir, which is one of the questions that we have received is from Dr. Rutuja. And she has asked, what is the age group for which PSI TB is approved by use by DCGI?
So right now, the current studies that we've done, we've just finished a study for more than 18, but we are very soon coming out with other age groups also. So it is safe to be used beyond 2 years of age, but currently the studies have given us an age group of beyond 18.
Okay. Second, sir, we have a question. Has WHO approved the use of the test kit globally?
So as I was telling you, WHO has already validated a few of these kits, and it is one of the recommended kits from WHO as well.
We have another question from Dr. Suvarna. She's asking dose for pediatrics age group. If we have any particular dose for pediatrics.
So it's the same as of now. Yeah.
So there's another question. What is the sensitivity and specificity of this assay?
So I don't have the exact numbers off the top of my head, but sensitivity was exactly as much as the currently used IGRA assays was found out, and specificity was much better as compared to the TST.
There are few questions which are for the cost of PSI TB. I would request them to drop us an email at the given address so that we can get back to you with the costings of the PSI TB test. There's one question from Dr. Ram. What has been innovatively modified to achieve the better sensitivity and specificity in PSI TB?
So I think over here, the biggest challenge was to find the right mix of proteins which do not interfere with NTM as well as in BCG. So it was the recombinantly manufactured or recombinantly developed ESAT6 and CFP10, which is which I would say is the juice of the product.
There's one more question. They have asked, are there any precautions to be maintained before administering PSI TB?
So the standard precaution that you would take even when we're administering any Monto's test, or for that matter, any injectable that we take, to obviously, so things like clean environment, clean hygiene, the syringe should not be reused, but it's the standard precautions, nothing beyond that.
There's also one more question. They're basically, I think so we can discuss this post the session, but they have asked for the implementation partners for the program for the scale. And if we are looking for some countries apart from India where high latent TB is there, what are some countries with high latent TB besides India?
So 3 or 4 countries that contribute most are obviously India, Indonesia, Bangladesh, Pakistan. So we like to be involved in management in TB in those countries, definitely.
There's one more question. ESTAT6 and CFP10 among NTM. They wanted to understand, Dr. Chauhan wants to understand among NTM.
Sorry?
ESAT6 and CFP10 among NTM, non-tuberculosis mycobacterium. I think so. This is we could also address this question later on. It's not clear. I mean, the presence of both proteins. They wanted to understand the presence of both the proteins among NTM.
So exactly. So these proteins are not present in NTM, and that's why we have decided to use them for any interferon gamma released assay based test, be it ex vivo or be it in vivo.
Are PSI TB and interferon gamma gold results equivalent?
Yes, they are.
There's one more question, sir. Who can administer this test? Can a DMLT or a nurse do it? Or is there a doctor necessarily needed?
So basically, we follow the exact guidelines as given out by the National Tuberculosis Program for the administration of Monto's test or the TST test. The same guidelines will be followed here.
And second, does the report needs to be signed by a pathologist?
Again, the answer would be the same. The reading is very easy. It can be read by even ASHA workers, Anganwadi workers. But based on what the guidelines of NTEP are, we'll follow exactly that.
So also there's one more question, sir. Do we need specialized manpower to conduct such tests in field, or we can train a non-medico for the same?
So when we say the word non-medico, if it includes a medico, includes healthcare workers, Anganwadi, ASHA workers who are trained to give injections, especially in remote areas and all. So they can be trained. And as I was telling you earlier also, we will follow exactly what the government has been doing so far for TSTs and MONTUs. If they have a workforce which is trained for those tests, the same workforce can be used here as well.
So I think so. Let us take another last question, and remaining probably we could get back to them individually with the details. I'll just have one more question. It is, can it be used twice on the same patient? Any recommendation on the gap between two tests?
Yes, it can be used twice, but there is a recommendation of a gap of at least, I think, 4 weeks between a test is repeated, because there is a chance of, I'll have to confirm whether it's 4 or 6 weeks, because there is always a chance of stimulating the immunity. And then if you do the test again, you might get a false positive. So there is a gap to be given between the tests.
Okay. So I am able to see, should we take another 1 or 2 questions? Is it okay?
Okay.
I think so. One is, from when the PSI TB test rolled out in India?
So it was given the CDSU approval post the ICMR study about, I think, in September or a little earlier last year, 2022. And now it's also being included in the national program now.
Okay. Thank you, sir. There have been a few questions. I think so there are some repetitive questions also, so which we have already attended. So again, I'll just mention there are a few questions where people are asking regarding the cost of PSI TB, which we will get in detail. You could drop us an email at the email IDs mentioned on the screen, and we will share the details with you for the costing of PSI TB injection. Okay. Thank you, sir, for highlighting the significance of PSI TB and its advantages in early detection of latent TB. Thank you for your valuable time. And if there are any queries, I would request everyone to please drop in the details at the email IDs mentioned here, and we'll get back to you. We will also share more updates on PSI TB, and we'll have such info sessions carried out henceforth in the coming weeks.
Thanks a lot, everyone.
Thank you, sir. Thank you, everyone. Good day.
Bye. Diti.